Thank you, All India Ophthalmic Society, for giving me this opportunity. It is a case report of herpes zoster ophthalmicus. Okay. So, first patient, a 63-year-old lady, she presented my routine ophthalmic OPD with maculopapular rash on the left side of forehead and upper eyelid region with swelling in cheek with acute anterior uveitis. This was the second 46-year-old lady. She presented with vesicular lesions on the right side of forehead and upper lid with lid edema and conjunctival congestion with chemosis. And this is the third elderly lady, 60-year-old. She presented with extensive developed crusted lesions on the right side of forehead. They were there since last 10 to 12 days with severe pain, and she had associated complete third nerve palsy. So coming to varicella zoster virus, it is a neurotropic human herpes virus of genus Alpha herpes viridi. The infection occurs in childhood and it spreads by airborne droplet and contact transmission. It results from reactivation of the latent varicella zoster virus within a sensory nerve ganglion, presenting decades later after the initial infection. The disease typically presents as a unilateral maculopapular or vesicular rash in a single dermatomal distribution. There are three stages. First, pre-eruptive stage, there is a burning or pain within affected dermatome at least 2 days prior to cutaneous eruptions, and associated symptoms can be headache, general malaise, photophobia. In acute eruptive phase, there are multiple umbilicated painful vesicles. Then they burst, ulcerate, and eventually dry out. This is the most contagious stage, and pain can be severe and unresponsive. Chronic stage, if there is severe pain that lasts more than 4 weeks, there is dysesthesia, paresthesia, and a shock-like sensation can also be there. PCR is useful for confirmation of suspected herpes zoster type pain if there is no associated rash. Coming to ophthalmicus, it is involvement of the ophthalmic division of the trigeminal nerve. 50 to 85% of the cases, they have associated ocular complaints, and rare manifestations can be sterile iris abscess, third nerve palsy, orbital fissure syndrome, Opex syndrome. It is an ophthalmic emergency due to the risk of vision loss if it is not identified early and treated well. Main risk factors for ophthalmicus are age more than 50 years and associated immunosuppression. So possible complications can be orbital cellulitis with a risk of secondary blindness, acute retinal necrosis, uveitis, epithelial keratitis, corneal inflammation, and if not treated, opacification. And patients with herpes zoster ophthalmicus, they have 1.3 to 4% increased risk of cerebrovascular events. So the treatment part, it can be supportive line of management. And coming to antiviral, systemic antiviral, in immunocompetent, we can try. We should give acyclovir 800 milligram orally 5 times per day for 7 days, or valciclovir. Then in immunocompromised, the dosing is 10 milligram per kg of idle body weight every 8 hours for 7 days. And in acyclovir resistant or severe form of cases in immunocompromised, we can give foscarnet. Then again, there is a role of antibiotics to prevent secondary infections, steroids, and topical aqueous suppressants if there is raised IOP. So coming to COVID-19 vaccination can increase the risk of varicella zoster activation. And these all available vaccines, they have been found to potentially reactivate varicella zoster virus. Coming to varicella herpes zoster vaccines, there are 2 vaccines, a live attenuated Zostavax, and second is a recombinant glycoprotein E subunit vaccine, which is Shingrix. And prevention and treatment, something about post-herpetic neuralgia. So while non-steroidals, they are not effective in post-herpetic neuralgia, we can try for tricyclic antidepressants, selective serotonin reuptake inhibitors, gabapentin, pregabalin. Then there are even newer methods are there for the management of post-herpetic neuralgia. Thank you.
Thank you. Any corneal involvement did you see in those cases?
No, ma'am. In these 3 cases, I could not see
Hutchinson signs. And seropositivity?
The third
HIV? Yeah.
If you see a new eruption, then you can give, but ideally it should be given within 72 hours. Then only it will be effective.
Dr. Anisha? She's going to take a look at an eye bombarded with effects of systemic lupus erythematosus.
Good afternoon all, myself Dr. Alisha, taking you to look at an eye bombarded with effects of systemic lupus erythematosus. So there is this patient, 24 years old female, who is a known case of SLE and lupus nephritis on treatment with hydroxychloroquine and mycophenolate mofetil, presented with left eye redness, foreign body sensation and photophobia. So on clinical examination, her best corrected visual acuity was 6/6, 6/9 in right eye and left eye respectively. Intraocular pressures were normal. And her right eye anterior and posterior segments were normal. Coming to left eye, so in the nasal periphery, we were able to see some sterile infiltrate, stromal thinning, vascularization, but the anterior chamber was quiet and the fundus was normal. So we came to a conclusion it's a peripheral ulcerative keratitis, and we started her on topical steroids, and at the same time her systemic immunosuppressants were continued and she responded well to the treatment. But later again she developed blepharokeratoconjunctivitis secondary to meibomitis and meibomian gland dysfunction, which again responded well to the systemic and local immunosuppressants and bilate hygiene measures. And then she developed an episode of severe ulcerative blepharitis with severe meibomitis in both eyes. So since this is recurring, we sent her eyelash samples for microscopy, and it came out to be Demodex, for which we gave her tea tree oil scrubs, and at the same time her immunosuppressants were continued. Then later again, she developed right-sided facial paralysis secondary to herpes zoster with lag of thalamus. Post this, she developed right eye exposure and neurotrophic keratitis with secondary microbial infection, which was treated with topical antibiotics. And later we had to do her right eye lateral paramedian tarsography, and presently right eye lag of thalamus is resolved and both eyes corneal surface is stable. Currently she is on lubricant eye drops and general ocular hygiene measures. So coming to systemic lupus erythematosus, it is a chronic autoimmune connective tissue disorder of multiple organ systems, including joints, skin, kidneys, and brain. It typically has a relapsing and remitting clinical course. The eye is frequently involved in SLE, and the disease may cause ocular involvement by several mechanisms, which includes immune complex deposition in the basement membrane of small blood vessel endothelial cells. And ocular complications have been reported in up to 1/3 of patients with SLE. Keratoconjunctivitis SHIKHA is the most common ocular manifestation, and corneal involvement has a wide spectrum range of severity, which may present as a very mild superficial punctate keratitis or ulcerative keratitis. So, literature has shown that the patients with systemic lupus erythematosus are on high risk with Demodex infestation, and globally herpes zoster has been reported as the most frequent viral infection in SLE patients. So this is a potentially life-threatening multi-system disease that is commonly associated with ocular manifestations. So because of the systemic nature of the disease involving multiple organs, collaboration among the involved specialists, including ophthalmologists, rheumatologists, nephrologists, and dermatologists, is often required for tailored therapy for each patient, and a better understanding of SLE pathophysiology will facilitate development of more effective treatment options. These are my references. Thank you.